you, and thank you also to CIPLA for sponsoring this. This is a very important topic, and I'm very happy that we do get to talk to you about it. So, I've been treating children for the last 26 years now, and I can tell you now, until maybe 3 years ago, 2 years ago, it was the same old, same old. We were just not getting anywhere and the bottom line is why we're not getting anywhere, because we didn't have pediatric formulations. And the last 2 years, it has changed so much that it's just like there's too much happening all at once. I mean, I'd like to tell you about one new formulation, but there's 3 new formulations all at once, which is great. Lovely to have choices, and it's really putting us in a great space. We're almost there. We're not quite there. We still have to get a couple of formulations. They're registered. We've got to get them in the country, but it'll be there in the next couple of months. And it's really going to change the whole pediatric scenario. In discussion with colleagues north of our borders, where they've already got these formulations, they just see these viral loads just plummet. It's just unbelievable. And we've got a lot to look forward to. So I'm going to talk about the basics of pediatric antiretroviral therapy, and then quite a big focus on the new formulations. If that's okay with everybody, please put your questions in the Q&A, and we'll try and answer them either as we go. Sometimes if I see one popping up, I'll have a look at it and see if I can answer it. Otherwise, we'll answer it afterwards. Or otherwise, Lesejo also likes to help with them as well. Okay, so I'm assuming that after all these master classes that you've got a fair idea about ARVs in adults. So we're going to focus really on the difference between adults and children rather than starting from scratch. I'm going to talk about these different topics. So first of all, viral loads. Now we know that the viral load tells about viral replication. The higher the viral load, the more this virus is replicating. If you take an adult starting or not on ARVs, and you'll see that there's a bit of a lag phase, and the viral load shoots up to high levels. And then as soon as the immune system becomes aware of the virus, starts to attack the virus, and then the viral load will drop, because as soon as the virus is produced, the immune system gets rid of it. And you've literally got a situation where you've got the virus producing 10 billion new viruses every day, and the immune system getting rid of 10 billion. And tomorrow you wake up nice and fresh in the morning, and another 10 billion viruses, and the immune system gets rid of it. And our immune systems do this for 10 years, getting rid of 10 billion viruses every day, until eventually, after many years, so the viral load remains low, we call it the viral load set point. After many years of fighting the virus every day, eventually the immune system gets exhausted, and that's when the CD4 starts to drop, the viral load goes up, and the patient gets sick. Okay, so that's the adult graph. Remember that, and now compare what happens with children. Look at the same graph for children. You can see it's very different. The viral load goes up, but it doesn't come down. Why? Because newborn babies don't have an immune system. So they can't fight the virus. So the viral load remains high at high levels for many, many years, 5 to 6 years, before it gets down to adult type levels. And obviously in that time, this virus is replicating and destroying the immune system. And that is why children get sicker much quicker than what adults do. So that's one very important difference that we need to be aware of between adults and children. The other is CD4 counts. Now, in adults, we all know, normal CD4 count is 500. They're only going to get sick when it goes below, 200. But in children, it's very different, because a normal CD4 in a newborn is about 1500, but most newborns have got a CD4 count of 3000, and it drops down to sort of 500 by 5 to 6 years of age. So after 5 years of age, CD4 count means the same as it does in adults. There's a cohort study showing that, and so after 5 years of age, we can use the CD4 count just as we do in adults. So if you phone our helpline and say, I've got a patient with a 7-year-old CD4 count of 220, we all know what that means. But they're under 5 years. That's where the CD4 depends on the age of the child. So you'd have to have a table and work out what is right for that child's age. Of course, us being pediatricians, we're a bit of a lazy bunch. I only speak for myself, though. So instead of having to look it up, we use the CD4 percentage, which is the same for all ages. So if the child is under 5 years of age, we look at the CD4 percentage. Over 5, we use the absolute count. So if you phone a helpline about a 3-year-old, you say, I've got a 3-year-old, the CD4 is 16%. Okay, so that's just to be aware of that difference. Okay, in terms of response to therapy, so peds always used to lag behind adults. But for the last good couple of years in clinical trials, they do as well as adults. But when you get into the real world, they don't. And the reason why it's taken a while to catch up is because children always lag behind in terms of studies, on PK data, even the new formulation we're going to talk about. We're talking about dolutegravir. We've had dolutegravir since 2019. The rest of Africa, it's been there a couple of years before that. You know what I'm saying? So we're still lagging behind in terms of pediatric formulations. There's no question. But also, I think once you get into the real world, why our response is not as good. There are a couple of issues, but the most important in my mind is the formulations in the younger kids and the whole issues of adherence, disclosure, everything else in your teenagers. So we've got a way to go. But to me, one of the biggest things we need to deal with is really is the formulations, because what we have at the moment, they are really struggling. Now, adherence, taste, and drug formulations are crucial. They're absolutely crucial in terms of ARVs. I always like to quote a study by Margaret Fischel. You can Google her. She did a study many years ago where she found, listen to this, 100% viral suppression. 100% of the patients had a suppressed viral load. Now, I know all of you out there are going to say, wait a minute, what planet was she on? Okay, this doesn't happen on Earth. And you're right, she wasn't quite on Earth. Why not? Because she was in a prison. She was working in a prison, and she had 2 or 3 burly prison officers who were shoving the ARVs down their throats, basically dots, okay, forcing them to take the treatment, and yet they got 100% viral suppression, which clearly illustrates what I've always said, is that if you can get people to take their ARVs, they will work. Okay. Yes, there are issues of transmitted resistance. I'm not talking about that. Just in general, the vast majority of patients are failing it because they're just not taking it. So adherence is very, very important. In children, you have to bring in as well, obviously, taste issues, formulations, palatability, dosing, twice daily, once daily. So there's a lot more to it in children than it is in adults. Adults just take your one tablet, right? In children, it's like, 3 different formulations, and do they have syrups, do they have tablets? It's a little bit more complicated. It's all because that children are little people. It's all about the little points. So let's just have a look at a little bit of detail. Obviously, we could talk for a whole day on adherence, but just in one slide, how can we make them take the treatment? First of all, simplify the regimens. If the adults can have 1 tablet once a day, why can't we do that in children? We still don't. At the moment, we're still stuck with 2 or 3 tablets or syrup formulations, often twice-day regimens. Very complicated. Okay, you want once daily dosing. You want to reduce the number of pills. Your fixed dose formulations coming. In adults, you've got 3 in 1. In children, the best we've got at the moment is 2 in 1. And even then, it's got its issues. We don't have 3 in 1 yet. You want to reduce the number of pills. So fixed dose combinations help with that. You also want to reduce the number of extraneous pills, right? Because really, you want to get in the bare essentials. If you're struggling to get meds into a child, you don't want to give them extra stuff just for frills, right? So I'm talking about cotrimoxazole, very important in children under a year, and those who've got a low CD4 count. Once the CD4 count is good, you can throw it away. Don't add it in just a little bit extra. I see this all the time, especially in the private sector. Just give it a little bit. Multivitamins. Yes, there's studies showing in people who are not on treatment, children not on treatment, that multivites with at least 3,000 units of vitamin A does prevent gastroenteritis, for sure. But I haven't seen a single study that says it's got any value in a child who's suppressed and on treatment. So you throw it away. You don't need it. Just go for the bare essentials. Reduce the number of pills. Just on that, I must say that, you've got to individualize your treatment sometimes, because I've got a couple of teenagers, young adults, okay, who don't like the big combinations, because obviously the more you combine the pills, the bigger the tablets. All right. And they don't want big tablets. So I've got 2 kids who are on 3rd line who are taking them as individual tablets. Once you get TLD, he's getting tenofovir, 1 tablet, okay, lamivudine 300 milligrams, 2 tablets, and dolutegravir, 1 tablet, because you won't take the combination. But it doesn't matter. If that works for him, it works for him. But as a general rule, sort of as kids get bigger, you want to try and reduce the number of pills, but you have to individualize. You want the volumes easy to measure. you've got a granny who's got to draw up this liquid, and you prescribe 3.685 milliliters, they struggle. As you get older, your eyesight's not so good. So, but unfortunately, our dosage chart, we've just got a new version just come out now, is very attuned to that, and it's like 2, 3, or 4 milliliters, nice and easy. But also the writing rubs off. Grannies don't know what the writing means on the syringes, so I'd use a blade, make a little nick in the syringe so they can know exactly to draw it up to that level. A little sticker to make a color code, so the green sticker, you draw it up to the same that line on the green syringe. Just make life easier, because if someone's struggling every day, it's not going to be sustained. Then, interesting, twice daily does not equal 12 hourly. We all know this, okay? Yes, in the old days when I started out, we had a protease inhibitor called Antiretroviral, had to be given exactly 8 hours on the dot. Plus, you had to be fasting like for 2 hours before and 2 hours afterwards. So you never ate, and you had to give your treatment exactly on time, okay? We've moved on. The formulation we have today lasts much longer in the body. We've got lots of flexibility. I think people normally say you've got 2 hours either side of the dose. It's supposed to be at 8 o'clock, you can give between 6 o'clock and 10 o'clock. I think it's a lot more flexible than that, but that's a fair guide. And if you forget it's more than 2 hours after, just take it. But you know what happened? We've drummed it so much, it's got to be 7 and 7, that if someone's on a taxi on the way to work, right, and they've got to take their medicine, they look around, no one's watching them, quickly take out the medicine, take out the drink, quickly take it, and make sure no one's watching. No one's going to do that on a taxi. Okay, you can tell them to take it before, but they don't. It has to be 7 and 7, and they say, oops, I couldn't take it because I was on a taxi. I've missed my dose. They don't take it. So we need to get on. Unfortunately, this dogma has crept in from the early days, and it's still there. And it's not just healthcare workers, nurses, doctors, pharmacists, counselors. It's the patients themselves. I know one of the hospitals I work at, we had a big drive to say, please move away from this. And yet the patient was still saying they're giving exactly on time. And we discovered they were telling each other in the queue while they were sitting down and waiting to see the doctor. So we've just got to move on, okay, because it actually is having an impact on our patients' adherence. Okay, I heard Juliet talk about this afternoon. I think it's a very important point. Don't always start hot on the first visit. Yes, there is good adult evidence that same-day initiation is really good. There's not very little pediatric evidence, but okay, there's good adult evidence that it does make a difference. But if the patient is not ready, you can stand on the head, they're not going to take the treatment. So you try for same-day initiation. But often if it's a child's been newly diagnosed and they're not ready for it, and if you diagnose a child, often maybe diagnosing the parent at the same time, it's a very traumatic situation. If they're not ready, keep on bringing them back, keep on counseling. I'm not saying delay for 2 years, but a couple of days, a week or so is not going to make a major difference, but it will make a major difference in terms of them taking the treatment. Also in pediatrics, make sure who is actually giving the treatment to the child, and that's a person you need to educate. Often it's not the person who's sitting with the child on the lap in front of you, maybe a mother who goes to work and got a caregiver or granny who's giving the treatment. Very important to find out who's that person, and that's a person you need to educate. Makes it more difficult because often the parents haven't told the granny or the caregiver what's wrong with the child, so they think the child is fine, and you've got to say, the child may seem fine, and you can't tell them the diagnosis, right? So you've got to educate them without giving the diagnosis. That the child's got a chronic condition. They look fine, they are fine, they're very healthy, but if you stop taking treatment, they will start to get sicker and sicker. So it's very important to make sure that whoever's giving the medication is aware of the need to give the meds, even if they don't know the diagnosis. Okay. What about taste? So in terms of the liquid formulations, unfortunately, the ones that we have in the young kiddies are very problematic. Lopinavir solution, it's 40% proof alcohol. Literally, it's the same as whiskey or brandy or vodka. And I would say, when I train face-to-face, would you give your baby a little drink of whiskey twice a day? And no one would do that, but yet we do it with this terrible tasting medication. Ritonavir, we used to have the solution, and ritonavir, I'll talk about that, is only used for super boosting, really, with TB treatment. The thing about the ritonavir is, well, the shelf life was very, very short. It was 6 months. So now they replaced it with adolescent powder, but unfortunately it also doesn't taste all that well. You can try and disguise the taste with peanut butter, soft foods, and chocolate milk, but really nothing really works. We'll talk about now later on. We've got the pellets, which are a little bit better, and I'll talk about it in a bit of detail. But the problem is that if it's not given properly, the taste comes out, and then you're back to square one. So unfortunately, it hasn't been a success from that point of view. In terms of tablets, so some tablets have to be swallowed whole. For example, the Paediatric tablets, ritonavir tablets. You can't crush them. If you crush them, the absorption goes down by 40%. So they have to swallow whole. But the problem is, if you ask a parent, can this child swallow tablets? They all say yes. They all say yes. Why? Because their idea of swallowing tablets is take the tablet, put it into a container, and take a spoon or pestle or mortar, whatever you call it, and crush it and give it to the child. That's swallowing a tablet. So you've got to say, can they swallow it whole without biting it or chewing it or crushing it? Okay. If they can, then they can get a little bit of a tablet or a ritonavir tablets. Otherwise, they need one of the pediatric formulations. Okay. Right. How do you know if they're taking the treatment? Well, the truth is, unless you see a suppressed viral load, you really don't know. Pharmacy records are very good. Okay. There's good literature supporting that if people are picking up their medication, it's a good indication that they are adherent. And in fact, in the new guidelines, that's going to be one of the criteria of assessing adherence is they must have 80% pharmacy refills. But I can tell you now, I have, and so I think most people, patients who collect the treatment every month, too embarrassed to say that the child's not taking it, and the child's not taking it. In fact, one of my patients, one of my patients went to the wasn't doing very well, and there were issues. A social worker went to visit them, and they just found boxes and boxes of unopened meds there. Someone just asked the question, does universal test and treat not apply to children? So what I'm saying is, yes, it's a good thing to do. There's little data to support it. Like if you look at the WHO guidelines, it says whatever it is, it's a good recommendation, but it's whatever based on very little data. And it's certainly something to aspire to do. But if the patient is not ready, then you don't do it. If the patient is not emotionally ready, then you don't do it. Okay, I hope that answers your question. All right, so pharmacy records are good, but they do have their issues just to be aware of. Ask them to bring the meds to each visit. Very easy to pour half the bottle down the toilet. And believe you me, the adults are not stupid. They know exactly how many tablets to take out, so it looks like they're taking the treatment exactly. The treatment chart, very nice. One of my colleagues walked into a waiting room in a clinic and saw a teenager sitting down there and ticking off extra doses on his top chart to make it look like he's taking his treatment. So what I do really is just to ask the patients, are they taking the treatment? And that's pretty successful. Okay, so I'm going to ask, can you break the tablets in equal halves? Some of them can be broken, some can't. It all depends on the technique used to make the tablet, because some tablets, are not homogeneous. So you might break it, you might find one half has got the one tablet, one's got the other half. So it depends. It's very difficult to say as a general rule, but as individually, we can, you can ask and we can help you with that. All right. Someone asked about neonates. I will talk about it later on. Okay, so getting back to ask the patient. I'm sure if you could talk back at me, you would say, what are you talking about? My patients lie. Am I right? Send me some thumbs if I'm right. Okay. But then we've got to ask ourselves, there, I've got a couple of thumbs, fantastic. We've got to ask ourselves, why do our patients lie? They're not bad people. Ooh, lots of thumbs. Okay, good. They're not bad people, right? So why are they lying? Why are they not telling us the truth? It's because they don't feel comfortable telling us the truth. And why don't they feel comfortable telling us the truth? It's because they are scared. They are scared that we are going to shout at them. So they'll tell us what they think we want to hear. Okay. So it's not the question that you ask, but it's the way you ask the question. If you say, are you taking your treatment? Yeah, of course I'm taking my treatment. right? No one's going to say no in that situation. But if you ask in a non-threatening way, they will tell you the truth. Not always, but very often they will. Like my teenagers, I don't even ask them. I say, hey, I see you're not taking your treatment. Your viral load is sky high. Listen, don't stress. It's pretty normal. Most kids your age have got the same problem. Come, let's talk about it. Let's see if we can help you. A mom is taking a bit of a solution. I say, how's it going with that medicine? You know, it tastes terrible. Most of my patients are spitting it out and vomiting it. Have you also got the same problems? And she doesn't feel bad to say, yes, you know, I've got the same problems. Okay, so if you ask in a non-threatening way, you will get them. I say, look, I'm not going to be cross with you, but I really want to help you. And the only way I can help you is I know if you're taking treatment or not. Once you say you're not going to be cross with them, they'll tell you the truth. So if you ask in a non-threatening way, it really, you know, they do answer you. Okay, so let's talk about formulations. You want to try and change the tablets, capsules as soon as possible. In the old days, it was like a maxim, you know, if you're a child equals syrup and adult equals tablets. Okay, and it's not true. I mean, you can teach a 3-year-old to swallow tablets. And that's what we did in the old days to get around the lopinavir taste. Okay, now we've got better formulations, but in the old days, that's what we did. I came across a child recently in the private sector, a 10-year-old who was on the lopinavir solution. Okay. And I said, you know, we've got better formulations. We don't use lopinavir solution. The child can swallow tablets. And I got an answer saying, thank you very much for your advice, but we'll continue with the solution. Anyway, but yeah, I think what's happened is that we as clinicians, first of all, we've got this thing of children equals solutions, adults equals tablets, but also there's this thing that I see coming through and through is if it's not broken, why fix it? The viral load is suppressed, why change it? And then I'll say, excuse me, what car are you driving? That's the latest model. Oh, okay. And what cell phone have you got? If you've got one of those old cell phones, you remember the old cell phones in the old days? If you wanted to send an SMS, you had to type each letter 3 times, like AA, BBB, CCC, you know, D, E, you know, and then the only game you could play on it was Snake. You remember Snake? Okay. Have you got a cell phone like that? No, I've got the latest model. Right. So they're upgrading their phones and their cars, but their patients are on bottles from literally from 2003. Okay. So we've got to get out of this thing of you know, if it's not broken, don't fix it. Okay. We've got to give them the best possible formulations. So I'm going to talk about those formulations. What I need from you is to use them. Okay. So getting back to our slide, you want to change to tablets as soon as possible. The lopinavir and ritonavir tablets can't be crushed. Others can be crushed. For example, dolutegravir can be crushed. There's a whole list that on the back of the dosage chart, it does tell you if they can be crushed or not. But if you're not sure, just phone a helpline and we can help you with that. Which one can be crushed, which one can be halved. Okay, we spoke about the taste. The lopinavir solution, ritonavir powders taste terrible. The lopinavir pellets are better, but the patient must swallow them straight away. Otherwise, the bad taste comes out. We'll talk about that now in a few minutes. Fridge storage, the lopinavir solution should be kept in the fridge until dispensed, and thereafter it's good for 6 weeks. As the child grows, you want to increase dosages. In old days, we used body surface area and weight, but these days we try as far as possible only to do weight, and we have a weight-based dosage chart. The one time where we still do surface areas, one of the questions people asked is in neonates, where we would, in certain situations, have to work out the surface area to calculate dosages. But most of the time, we use weight-based. It's been simplified to make it easier for us. Okay, this is the dosage chart. I can't see it's covered by the ribbon, but I think this is the 2021 dosage chart. We've got the 2022 dosage chart, which is available. I'll tell you about it later on where you can get hold of it. On the left and the right, there is a column of the weights. You just find the child's weight, and then you just move to the formulation you're looking for, and then it will give you the different doses. Okay, and you see there's different formulations that you could possibly give the child. So you need to decide which one they need. Sometimes you have to ask the parents, sometimes you try, see can they swallow tablets or not. But it's not like an adult, this is it. You've got to work out what is best, and sometimes you involve the child. You know, if it's an older child. You know, I used to just like say when I wasn't, before pre-COVID days, when I used to see patients face to face, I used to say, no, which ones, so you can have this or this, which ones would you prefer? And if the child chooses, if they feel they've chosen it, more likely that they're going to take it. Okay, so somebody asked about when can we give TLD. So let's start at the beginning. So neonates get their own regimen. I'll talk about them at the end. Good reason to stay till the end if you want to know about neonatal dosages. Right, but from 3 kilos to 20 kilos, the regimen that is given in first line is a Baclofen 3-TC and lopinavir. All right, at 20 kilos at the moment, you can give a Baclofen 3-TC and dolutegravir because we don't have a pediatric formulation, and dolutegravir really should be given from 20 kilos. The formula that we have, the 50 milligram tablets, you can push it. There is data to push it, and certainly in the third line committee, we are pushing it. But I wouldn't do it as a routine. But if you're in a situation where you're stuck or you're discussed with an expert and the patient needs to go on dolutegravir, but you don't have the pediatric formulations, you can go below that, but speak to an expert. There is data, there's very good data, but I wouldn't do it across the board to everybody. Okay, so this is the 2019 guidelines. From 20 kilos till 35 kilos, a Baclofen 3-TC and dolutegravir. And then at 35 kilos and over 10 years of age, that's when they can get TLD, providing that, number one, they are over 35 kilos, over 10 years of age, also have a suppressed viral load from the previous regimen, and renal function is normal. So I must have those 4 things before you can switch to TLD. Over 10 years, over 35 kilos, suppressed viral load below 50 in the last 6 months, and EGFR above 80, which you'll see that in the later slide. Okay, so that's where it is at the moment. In the rest of Africa, they've been using the cutoff as 10 years and 30 kilos. And the reason why we didn't use that in our guidelines is because it was a mathematical model for that dosage. There wasn't real world expertise, there wasn't PK studies. But now it's been used for so many years in Africa at 30 kilos. So in the new guidelines, may change, but certainly in the discussions, it's most likely going to be 30 kilos and 10 years for TLD. So I hope that answers the person's question. Okay, so that's where things are at the moment. Obviously, when the pediatric dolutegravir tablets become available, then it'll be a Baclofen 3-TC dolutegravir, not from 20 kilos, but from 3 kilos and 4 weeks of age. Okay, but we'll talk about that now. So it's going to change the whole thing and make it much more aligned to the adults. Obviously, we can't use tenofovir in these younger children, but at least we'll have the dolutegravir regimen, and it's much more tolerable than the lopinavir regimen. Oh, let me see if there's any. Oh, if you write long questions, I won't be able to answer them. I'll have to answer them afterwards. Okay, so the third line committee meets every month. We've got a meeting tomorrow. So if you email me who your case is, I will make sure it gets dealt with tomorrow. Okay. Not on the topic, but there's your answer. Right, now, the thing that has really shaken the pediatric world are the new formulations. As I say, we've been stuck with formulations literally from 2003 with no changes. And Peds is always the last to get the changes. So let me talk about some of the really exciting new formulations. So first, let's talk about the pellets. Okay, so basically what they are little lopinavir tablets. It's not granules, they are pellets. They are tablets, proper tablets, but they're just little. There's 42 of them inside their capsule. You have to open them up and sprinkle them onto soft food. You can't stir them, you can't crush them, can't dissolve them. You just literally sprinkle them onto food. As you'll see in the video, you can put a little bit of food on top of it and you give it to the child straight away. I've swallowed them, so excuse me, there's no taste. But if it sits in the mouth for too long, or sits in a spoon of food for too long, or even the worst, if you bite it, the bad taste comes out, and then you've lost the whole story. It is slightly better tolerated than lopinavir solution. Under 6 months, we don't use it because, first of all, they're not on solids. So if you mix it with the liquid runs off the tongue and it sits on the tongue, and then they get the taste coming out. And also because they are at risk of aspiration. So we use it over 6 months of age. In the DRH, it's used because it is more expensive than the solution. It's used for patients over 6 months of age who are not tolerating the lopinavir solution, which I would say is probably every patient. But that would be the thing. And unfortunately, it hasn't been as successful. And I think it's why it hasn't been successful. It's dependent on technique. If it's done properly and given straight away, they seem to tolerate it. If it sits for too long in the spoon, okay, or in the mouth, then the bad taste comes out, and then they don't tolerate it as badly, as much as that. So we've got a quick little video. That's what it looks like. It's these capsules. You can't swallow the capsules whole. Obviously, there's young children who can't swallow the capsules anyway. It's not designed. It's just designed to hold these little pellets. So you must open them and sprinkle them out. Okay. So I don't know what happened to my video. Maybe it will come. Maybe it's hidden, but it doesn't matter anyway. Okay. So basically, what you would do, you just open them, sprinkle them onto a spoon of cool soft porridge or yogurt, whatever it is, and then put a little dollop on top and give it to the child straight away. And that is how you're supposed to do it, but it unfortunately doesn't always happen. You will get these slides, and in the slide there's a link to the video, and you can get the video if it doesn't come up. Okay, ritonavir powder. When do we use ritonavir on its own? The old days, the solution. So the most important would be super boosting with ritonavir when the patient's on TB treatment with rifampicin. The enzyme cytochrome P450 that breaks down ritonavir. Okay, if they're given rifampicin at the same time, it becomes hyperactive, okay, because it's induced and gobbles up all of the ritonavir. You get low levels and you actually get resistance. And this patient ended up in third line. So in adult patients, you would double the dose. We'll talk about it later on. In children who are on the solution, you can't double the dose because the levels are still too low. You have to add in extra ritonavir. So that's where the ritonavir is used. You could also use it as a booster with atazanavir and darunavir, which don't have their own booster, unlike the ritonavir. But most of these patients are older kids who can then swallow the tablets. They don't need the solution. So the solution, we don't have it anymore, fortunately, because first of all, it tasted terrible. The second of all, it had a shelf of 6 months. So literally by the time it arrives in your clinic, it's time to throw it away. So we've got this powder, which is largely just used for super boosting with TB treatment. It's got a shelf life of 36 months, doesn't need refrigeration. It's a 100 milligram sachet. Can be sprinkled over soft food or liquids, any soft food or liquids. The cons are, first of all, it tastes terrible. It's got to be used within 2 hours of mixing with food, but literally if you give it more than a few minutes after mixing it, so let's say this is the ritonavir, within 2 hours is fine. The sachet is 100 milligrams. If you give 100 milligrams on its own, you can just sprinkle it over food or liquid. If you need less, 60 or 40, whatever it is, then there's like an 11-step process. Draw up 9.4 mils, add it to a cup, to a container, add the powder, shake it for 90 seconds, you've got to time yourself, let it stand for 10 minutes. It's a bit of a nightmare. So you want to try as far as possible only to give either 1 sachet, 2 sachets, or 3 sachets, and nothing smaller than that. Even if it means a little bit of an overdose, so that you don't have that nightmare, because it's very hard for the caregivers to do. Okay. As we said, the ritonavir solution is no longer available. The powder is supposedly freely available, but often I get calls on my helpline where people say it's out of stock. But please don't double the dose if the patient. Please don't double the dose if the patient needs TB treatment and you can't get ritonavir. Those patients end up on third line. Okay. There are other options. Phone the helpline, but don't double the dose because I don't need another third line patient. Thank you. That's what they look like. There's a solution, so the powder, these sachets. That's a 10 ml syringe, so you can see the size to compare it. And as they give 1 sachet, 2 sachets, or 3 sachets, don't give smaller doses because it's much more difficult. Right, the next one, which is a very exciting formulation. It is available already. We should be using it. We're still not. And I'm seeing some really good questions coming through. Keep them going. So this is abacavir 3TC 120/60 tablets. We already have an abacavir 3TC fixed dose combination, okay, of 600 milligrams of abacavir, 300 milligrams of 3TC, and you can use it from 25 kilos. So we've got that one already, but we don't have anything for below 25 kilos, and that's where this one comes in. It's 120 milligrams of abacavir and 60 milligrams of 3TC. They are scored, they're dispersible, They can be used from 3 kilos till 25 kilos. Why do we say 25 kilos? Because as I said, at 25 kilos, you use the adult tablets, but you could use them over that. If the child can't swallow tablets, you can certainly use it. There is a dose. It's not a dosage chart, but there is a dose for over 25 kilos. And it can be mixed with water, mixed with breast milk, can be chewed, it can be swallowed whole, can be crushed, many different ways of taking it. It's literally going to replace all the other pediatric 3TC in the back of formulations. It's given once daily, makes it much easier in terms of adherence, because not all in the dosage chart, younger kids used to get twice daily still, but now they can give once daily as well. The 2 generics are already registered in South Africa. They are available both in the private sector and in the DOH. They're available. It's just a question of using it, and they're cheaper. They're cheaper than the individual formulations. The one is tasteless, and the other one's got a strawberry flavor. They're both very well tolerated, and it's just something that is there, and we should be using. Now, if you look on the dosage chart, the 2021 dosage chart, which you have already, it's there. It is the third column. In red, I'll sort of enlarge it a little bit for you. You can see it's either 1 tablet, 1.5, 2 tablets, 2.5, or 3 tablets, and then at 25 kilos, you go into the adult 600, 300. So it's a fantastic, very easy in terms of dosing. It's 1, 1.5, 2, 2.5, or 3. They are scored, so very easy to break, and literally can be mixed with water, with breast milk, with they can be broken, crushed, mixed with food, chewed, swallowed whole. Okay, now, thank you to everybody out there for checking up on us. I really appreciate it. It's fantastic. It's so great to being on our helpline. We do get people asking questions. We also get people criticizing us, and it's really good. And please keep them coming, because we are just humans, and we make mistakes. So we've been told by people out there they're not using this combination of 120/60 because we're underdosing, especially in the weight band between 20 and 25 kilos. So I had a look at it. Maybe they're right. Okay. So what I did on this chart, I've got in the middle the back of a 3TC 600, 120/60, and next to it I put the 3TC dosage. And then on the other side, I worked out what dose of 3TC will that formulation give us. So you can see in the first weight band, the combination will give you 60 milligrams of 3TC, and the individual will give you 60. So that's fine. The next one, 90 and 80, that's fine. Next one, 120, 120, all good. 150, 150, all good. And then wait a minute, look at this. In the 20 to 25 kilos, 180 milligrams in the combination, and 300 in the old dosage chart. And the one below that is 300, 300 is fine. So maybe this is what they're talking about. Where I see all the faces, people putting faces. All right. Whereas 180 milligrams in the 20 to 25 kilos, and in the old days, we were giving him 300 milligrams of 3TC. So is that where we were underdosing? So let's see if that is underdosing. So what I've placed on the right is what the correct dose of 3TC should be. Let's look at that. So in the first weight band, 48, they should get. They're getting 60. That's okay. It's a very safe drug. You can overdose a bit. They should get 80 in the next band, and they're getting 90 and 80. It's good. 112, they're getting 120 is good. 160, 150 is good. They should get 200, and they're getting 180. Okay, so that's good. But wait a minute, look on the left. In the old days, we were giving 300. So it's not that we are underdosing with our present formulation. We were overdosing in the old formulation, and nobody criticized us for that. Okay. Why were we overdosing? Because we only had 150 milligram tablets. So you've either got 150 or 300. So you had to give an overdose to make it simpler. We didn't want to go to syrups. And because it's a very safe drug, there's no problem in overdosing. Okay. So it's not that we are currently underdosing. It's that we were previously overdosing. But now we have a pediatric formulation. We can make the dose much more accurate. And so it's fine. So please, those of you who are feeling that you are underdosing with this formulation, this is WHO dosing. It's not just us. This is the standard dose, and it's fine. There's no problem with the dose. I see I've got at least one thumbs up. Thank you so much. Okay, so that 180 milligram is the correct dose. Oh, I got a few thumbs up. Thank you. This is so nice, these emojis. Fantastic. Good. I'm happy I explained that to you guys. Right, how do you administer this dispersible tablets, 120/60? So either water, or if they don't have a clean source of water, you can use breast milk. So first of all, you have to use the right dose. As we said, 1, 1.5, 2, 2.5, or 3, which we will calculate for the tablets for the patients. They will then put that into a container, and you can go either way. You can either put the tablets into the container and add water, or add water in and add the tablets. Doesn't matter. I've seen both methods. So you add the tablets to the container, you add your 10 mils of water, 2 teaspoons, and you stir it until it dissolves. If it doesn't dissolve fully, then just add a little bit of extra water until it dissolves, up to another 10 mils. Sometimes in the bigger doses, where you may be using 3 or 4 tablets, you might have to add a little bit extra. Okay, but you stir it till it dissolves, and once it's fully dissolved, okay. And also remember, if you have to break it to 1.5 or 2.5, it's scored, so it's quite easy. Well, once it's fully dissolved, then you give it to the child, and you can choose either let them drink it straight from the cup if it's a bigger child, or use a spoon if it's a smaller child. Okay, very straightforward, easy to give, well tolerated, can be swallowed whole, crushed, mixed with food, or dispersed with water or breast milk. So it's there. Okay, it's the latest model cell phone. Okay, please don't leave them on the old model. Upgrade your patients to this. It's already available in the DOH and in private. Okay, so there's no excuses. We're not waiting for the new formulation. It's there. It's available. Please use it ASAP. Okay, cool. Right. Let us move on. And we mentioned of the formulations, one is strawberry, one is tasted, but they're both very well tolerated. Cool. Next thing I want to talk about is an Abacava 3cc dolutegravir 600, 350. This is available, been available in private for many years, but it's now available on the DOH as well. You can only use it from 25 kilos. It can be crushed, and you can use, so if you've got a patient on Abacava 3cc dolutegravir, and it's a big child over 25 kilos, and not yet at TLD age or weight, they can get this one tablet. It is a big tablet, but it is crushable. The one tablet Nocte, and obviously it's all 3 drugs together, makes a big difference. It's available, and it's on the new tender. It's available both in private and in the DOH as well. Another reason to upgrade your patients. Right, but what about the smaller patients? Oh, what's going on here? Sorry. I had a slide that was gone missing. Doesn't matter. Okay, so for the pediatric, I don't know what's going on here, but we're okay so far. For the pediatric patients who can't take such a big dose, there is the smaller pediatric Abacava 3cc dolutegravir, which is not yet available. Okay, so it's still sitting at SAPRA, and talking about registration sort of mid-year next year. So it's still in the future, but just to be aware of that. But at the moment we do have this one, the 600, 350 in your older patients about 25 kilos. Okay, let's talk about the dolutegravir formulations. So our present formulation that we have, the 50 milligrams of dolutegravir, is a film-coated tablet. It's a film-coated tablet, which you can use, as I say, from 20 kilos in a push. When you've got a third-line patient or patient who's not tolerating lopinavir, you can go down below that, but do it on the advice of an expert. I wouldn't do it routinely at this point in time. But what about these new dolutegravir formulations? So we have dispersible tablets. Now, they're different from the film-coated. Their bioavailability is different. It's much more bioavailable, 1.6 times more bioavailable than the formulation we have now. We've got a 10 milligram scored generic tablet. There's 2 of them. Can be used from 4 weeks and 3 kilos. The 2 generics already registered with SAPRA. They should be available in the country in the next couple of months. Can be added to water, milk, or soft foods. And they're already part of the new guidelines. As soon as they're published, you'll see, I'll continue that they are in there. It's not bioavailable to what we have at the moment. So, for example, the 150 milligram tablet that we have at the moment, if you had to give the same amount in dispersible tablets, it would be 30 milligrams. You work out 30 times 1.6 gives you 48. So there's your 1.6 factor. So the new tablets are 1.6 times more bioavailable than the old film-coated tablets. So if you've got patients who are on old film-coated tablets and you change the new ones, the dose will be different. And it's not that whoever advised you gave you the wrong dose. It's just the formulation is different. Okay. So here we have a video. I hope it projects well to show you how to use these the new formulations.
Are you ready for your medicine? Are you still struggling to give your baby the medicine? I've seen that it has been difficult in the past.
Not anymore. This new medicine, pediatric.
Sorry, there's some problem with this. Try again.
Are you looking for the medicine?
Are you still struggling to give your baby the medicine? I've seen that it has been difficult in the past.
Not anymore. This new medicine, pediatric or PEDs, giving my child his ARVs is so easy now. No more bitterness or having to.
Sorry, there's a problem. I don't know why it's not projecting it.
Medicine.
But you might just get the sound and not the video.
I've seen that it has been difficult in the past.
This new medicine, pediatric or PEDs, giving my child his ARVs is so easy now. No more bitterness or having to give your child their medicine twice a day. They take it once a day and it disperses in water and it tastes like strawberries.
I can't believe it. You must be joking. Medicine tasting like strawberries.
It's true. PEDs can also be mixed in the same glass of water as abacavir and amyloid. So the child can take all their ARVs at once.
Really?
Apologies, so it's not showing you the video, it's just showing the sound.
The first step is counting the right number of tablets based on the doctor's instructions and adding that to a clean empty glass. Just like the other ARVs your child takes, dose of PEDs is based on how much your child weighs. My child weighs 8 kilograms, so that is 1.5 tablets. So I take 1 tablet, and now I take another and break it in half, which is easy because it is scored. So it has a line down in the middle. Now, once the tablets are in a glass, you only need to add a small amount of clean water to the glass, only 1 to 2 teaspoons. Next, stir the water until the tablets dissolve. If the tablets are not dissolving or are still in big pieces, continue to stir the medicine while slowly adding a little bit more water, up to an extra teaspoon until the tablets dissolve. And there we go. Now you're ready to give it to your child.
It looks like there's still medicine on the sides of the glass though. Don't they need to take it off?
Yes. After they finish drinking the medicine, if there's any medicine still in the cup or on the sides of the cup, you just add 1 more teaspoon of water to the cup, swirl, and give it to them. This is to make sure that your child is getting all of the medicine. Continue to do this last step if any medicine is still in the cup. You can even just use the teaspoon itself to scoop and give any leftover PEDs to your child. And remember, your child must drink the medicine either straight away or at least within 30 minutes. And that's it. So simple, so easy.
Wow, it is. But what about the other ARVs? Why didn't you put them in together?
I didn't mix them both together here, but as I said, yes, you can easily mix abacavir and amyloid with PEDs in the same glass. If you want to mix both together, all you need to do is follow the same instructions. First, count the correct number of tablets of both PEDs and abacavir and amyloid and add to an empty cup. When you add clean water, just need to add 2 to 4 teaspoons of water so it can all dissolve.
My baby is still breastfeeding. Would I give it to them with breast milk instead?
The nurse said PEDs is recommended to be mixed with clean water. But if a child is unable to take it with water, it is okay to mix it with other liquids or foods, such as milk, juice, yogurt, or porridge. If you do mix other liquids or foods, use the same small amounts of liquid or food I mentioned before to ensure that your child is able to take a full dose of medicine.
Wow, this does sound so much easier. When we go to the clinic next week, I will definitely be asking my baby to switch to PEDs DTG.
Okay. So apologies for the fact that the video didn't present. I don't know why it didn't. What I will do is I'm going to send Listejo a lot of links, and I'll include the links for this video and the video for the pellets as well. She'll have access to all of that. Then I see while you were watching the video, I was looking at questions. I'm being bombarded with questions. Why am I saying that you've got to give dolutegravir Nocte? It's got to be given Marne. Didn't I know that? So no, I didn't know that. And it's amazing. This is how these things creep in. Okay, we've got to make it as simple as possible and as pleasant as possible. And most children struggle with morning dosing. Okay, by the time you can get a school child up, they're already late for school. Breakfast is on the run, and medicine gets forgotten. So most people prefer nighttime dosing. And I see that some people are saying, but you've got to give dolutegravir in the morning because of insomnia. How many patients have you seen with insomnia? I've seen not one. Okay, it's very unusual. And even in the studies that were done, which said that you get insomnia, it was 1%. So now you're going to punish 100 out of 100 patients, and punish 99 patients by forcing them to take the medicine in the morning at a most unpleasant time for the one patient who's going to get insomnia. I don't know where this crept into our psyche. Don't do it. Let them choose when they want to take the medicine, when is the best time. If they get insomnia, you move it to the morning. It's as simple as that. I've seen one of the well-known medical aids say it must be given in the morning. You're punishing 99% of your patients, in fact more, because in the real world, we hardly see insomnia. So please, it's not a rule. It has to be given in the morning. I give it at nighttime, and I say I ask them, when's the best time to take treatment? When do you prefer, morning or nighttime? If they say nighttime, I say fine, take it at nighttime. But if it gives you insomnia, which is very rare, just move it to the morning. Okay, so thank you for all those people who asked that question. And I see I'm getting some hearts. Thanks, fantastic. Very good. Okay, good. So that is the dolutegravir dispersibles. I'm sorry about the video not coming through, but you'll get the real video you'll be able to look at. But the sound and explained very nicely. And show the patients that video. That's what I do with the pellets. I haven't had any patients with dispersible dolutegravir yet, but with the pellets, I show them the video. I have it on my phone, show it to them, and it helps them to be able to take it properly. Okay. Now we're talking about another fantastic formulation, which is also available in the country at the moment, and that's the abacavir, lamivudine, lopinavir, what they call the 4-in-1. Okay, all four the present medication that these children are taking in one. It's 30 milligrams of abacavir, 15 of lamivudine, 40 of lopinavir, and 10 of ritonavir. It's all in a powder. It's in a capsule, which you just open up the capsule. It's a big capsule. You just open it and sprinkle it out onto soft food or liquids, and it tastes delicious. It's strawberry tasting. It tastes like strawberry ice cream. It is really, really nice tasting. I don't know how they managed to mask the taste, but they did. So it's available, but if it came out maybe a year or two back, it would be our standard first-line regimen. But now it's come at the same time as dolutegravir, so dolutegravir is going to take first place, and so we'll be using it in those patients who are either not tolerating the dolutegravir or have failed the dolutegravir, or even in certain situations where we want to see, can we get them to suppress on their PI before changing to dolutegravir. So we know that the PI is active in case the dolutegravir regimen doesn't work. We've got an active PI. We might switch them to the 4-in-1 to get them to suppress first. And if they suppress, they could then switch to dolutegravir, knowing that if it doesn't work, we've got an active PI. So it is going to have a lesser role, because of the timing coming at the same time as the pediatric dolutegravir, but it's a great formulation. It's lovely. And if we do need a second-line regimen for these patients, if they're not tolerating the dolutegravir, we will have a fantastic regimen. So it's really great to have, drought and then flood. That's what we're having. But it's okay. I'm not complaining. And it will be available both in the private sector and in the DOH. Right, so this is the dosage chart that we spoke about, the 2021, and now we have the 2022 dosage chart, which I've written provisional here because my slides are outdated. It's already available. You can get it from the Clinician Society website. I have got the link. I will put it up at the end. And it includes, obviously, the abacavir 3-TC fixed dose combination, which was there already. It includes the 4-in-1. It includes the dolutegravir pediatric formulations, both without TB treatment and with TB treatment. So everything is in there. And certainly, as soon as these formulations are available in the country, in private sector, we can use it. And obviously, once the guidelines come out in the DOH sector, we'll be able to use it. So thanks really should go to Dr. James Nuttall, who's this has literally been his baby from the word go, and he makes sure he updates it every single year. Obviously, we all contribute and help him, but he's the one who puts it all together. and also the Clinician Society and the hotline in Cape Town are also very instrumental in producing this. So thanks to everyone. It's fantastic to have such a lovely dosage chart, and as I said, it is available now. You can get it and download it. It will be printed, obviously, in time for the new guidelines, and people will have hard copies as well. Okay, just a few other things I wanted to talk about. Somebody asked, can you take dolutegravir with Kidivite? Remember that this is not a talk about dolutegravir. I'm assuming people know that that dolutegravir, you can't give it together with positive cations. So if they're with minerals, you can't give it. So Kidivite, most of the multivites have got minerals, so you can't give it at the same time. You can then give, if you want to give the Kidivite in the morning and give the dolutegravir in the evening, or vice versa, that's fine. But most of the time, so once they're well, I stop the vitamins. They don't need it. They don't need it. You don't need to give. Why go for a once-a-day regimen and you're giving something in the morning, so you're actually back to twice a day? Rather go for once a day. So I'd use it initially, the vitamins, until they're stable, and then I drop the vitamins and give them a once-a-day regimen. Okay, so TB treatment and ARVs, the potential problems, obviously the increased pill burden. I calculated once for a patient who's on, let's say, a second-line lopinavir regimen, adult, where you're doubling up the dose. Okay, I worked out they need something like 18 tablets a day. Work it out for yourself, okay, including the TB tablets, the RIFA-4. So it's a big pill burden. Overlapping toxicity is usually liver dysfunction, which is a big problem in adults, but fortunately in children, we hardly see it. I'm very thankful, because I keep forgetting what you're supposed to do. Iris, we see with many different diseases, but here we're talking about TB, where they've got TB, they're not reacting to it because their immunity is low. Put them on ARVs, immune system recovers very quickly, and the body starts to fight the TB, and so they get sick. So you want to then start with the TB treatment, if you know about the TB, for a short period before starting the ARVs. And then the last one, which is the most important one, is cytochrome P450 CYP3A4 induction. This is the enzyme that breaks down the protease inhibitors, many other drugs as well. And in a normal situation, it sort of nibbles at the drug, but if you give rifampicin with it, it makes it hyperactive and gobbles it all up like a Pac-Man. Okay, so you get low levels of your active drug, your PI, non-nucleoside. Dolutegravir is affected as well. And then also, not only does it not work, but you also can develop resistance. So how do we get around that? This is from the 2019 guidelines. So neonates, it says there are interactions, seek an expert. Okay, I won't go into that now. If they're on the back of the lopinavir regimen, so if they are taking the adult tablets, not the adult tablets, they're taking lopinavir tablets, either pediatric or adult, okay, swallowing it whole without chewing it or breaking it or crushing it, you can double the dose like you do in adults. But if they're taking the solution or the 4-in-1 or the pellets, then you have to super boost with extra ritonavir, the ritonavir powder, as we discussed. If they're on a dolutegravir regimen, then as in adults, you would add an extra dose of dolutegravir approximately 12 hours after the initial dose. And you continue with this boosting, whatever you're doing, for the duration of TB treatment, and an extra 2 weeks. Once you stop TB treatment, for an extra 2 weeks to allow the liver to recover, and then you can drop the extra boosting, whatever you do. Okay, very important. Don't forget, because unfortunately, if you forget this, okay, I end up with another third-line patient. And believe you me, I've got enough third-line patients. I don't need any more. Okay, and on the dosage chart, the green column tells you about what to do if they're on a ritonavir and rifampicin. The blue, dolutegravir, the left one is dolutegravir in the absence of rifampicin, and the right is with rifampicin, obviously with the extra dosage. The new dosage chart does the same thing as well. But the green one is lopinavir, ritonavir, and rifampicin, and you can see, depending on whether they can swallow the tablets whole, if they are on the left side, if they can't swallow tablets and they're on this lopinavir solution, or the 4-in-1 or the pellets, there you would just add in extra sachet of the powder, either 1 sachet, 2 sachets, or 3 sachets, depending on their weight. If they can swallow the lopinavir tablets whole, then you would just double up the dose. And that's that green column in the middle. Okay, in terms of side effects, generally same side effects we see in adults as in children, but they're generally less common, must say, in children. Some are more common, like the efavirenz rash. In the old days, when we used to use efavirenz, and some only occur in children. Example, osteopenia from tenofovir. It's not really true because you do get in adults, but obviously children are on it at a much more delicate stage when they're growing, and we do worry. And somebody did ask about the osteopenia, and I must say it is a worry. It is a worry because nobody is doing DEXA scans. In the early days when I started using, I mean, I had a 3-year-old that I put onto tenofovir because she had hepatitis B as well, cured of hepatitis B. I did DEXA scans on her, and actually it was pretty good, and there was no issues. But we're not doing DEXA scans, so we don't know, and it is a big worry for the future. But maybe that TAF we'll talk about now I'm definitely showing the wrong slide because I didn't even talk about TAF. TAF is also we think may have less effect on the bones and the kidneys. Although the initial studies are showing it's really only in those patients who are boosted with a boosted PI that TAF does have benefit. Yeah, so the jury's out. We don't know, but people are using, have been using it for many years in pediatrics, and it doesn't seem to be a major problem. But it's just something that we have to monitor. So just to talk about TAF, I'm going to go back and show you the slides. So TAF is a prodrug of tenofovir, just as TDF is a prodrug of tenofovir. TAF is supposedly better on the kidneys and the bones, but as I say, a meta-analysis showed that it's only really beneficial in those patients who are on, for example, ritonavir as a booster, or cobicistat they use overseas as a booster. So in that situation, the TAF does seem to have a beneficial effect on the kidneys and the bones, but in other situations it doesn't really. TAF also has other metabolic effects as well. The benefit and the downside of TAF is that it may be associated with weight gain. The benefit of TAF in pediatrics is that, first of all, it's a tiny tablet, because that's 25 milligrams that you're giving. If it's given with a boosted PI, you give 10 milligrams, but normally the dose we give is 25 milligrams as opposed to 300 milligrams of tenofovir. So your fixed dose combination of TAF-Ed, which is TAF, itracitinib, and dolutegravir, has got 25 milligrams plus 200 plus 50, so 275 milligrams, and our present TLD has got 300 plus 300 is 600, 650. So it's 275 compared to 650. So it's a much smaller tablet. The kids love it, and you can use it from 25 kilos and 6 years of age. So if you've got patients who need to go into TLD, but they are too small, they're under 35 kilos or under 30 kilos in the few new guidelines, or under 10 years, but they're over 6 years of age, they can get TAF-Ed. So it's something that there is a great demand for. It's going to be available both in private and in the DOH. DOH, I suspect, will only be on a buyout, so it won't be so straightforward. But if you have patients where they have resistance and need to go into TLD, but they're too small, that will be available. It is registered, a couple of formulations registered, and should be in the country in the next couple of months as well. Okay. In terms of renal function, obviously, if the patient is on tenofovir or on TAF, you would need to calculate renal function. If it's an adult or child over the age of 16, the guidelines are saying use the MDRD equation. And the lab does it for you if the patient's over 18 years of age. So over 18 years of age, the lab will calculate, but they flatly refuse to do it in children under the age of 18. So between 16 and 18, they won't do it. So there is a formula. It's complicated. You can't work it out on a piece of paper. There is an app you can just download, a EGFR app. It's quite straightforward. If you have phone, our helpline will help you with it. If you want to do it yourself, just remember to choose MDRD and also to change the creatinine, instead of milligram per deciliter, to change to micromole per liter. Okay, and then you can just calculate it. It's pretty straightforward, and you can do it. But as I say, we're happy to help you. So the lab won't do it from 16 to 18. If they're under 16, so 10 to 16, then you use the Cunahan-Barrett formula, which is on the right there, which is the height in centimeters times 40 divided by the creatinine in micromole per liter. Quite straightforward, but if you're struggling, we'll do it for you. And remember, pregnant women, because of all the excess fluid on board, the formula doesn't work. You go by the absolute, and it must be below 85 to use creatinine. In adolescence, also the cutoff is above 80, EGFR above 80, as opposed to in adults where it's above 50. Okay. Right, I'm just going to finish off with two special populations, the neonates and adolescents. So neonates are complicated. Okay, first of all, we said lopinavir with 40% proof alcohol, also 15% propylene glycol is toxic to the neonates. And so you can only use it when the baby is 14 days of age. And if it's a prem baby, you can only use it once they get to 14 days of corrected age. So if they're 6 weeks prem, you've got to wait until they're 8 weeks of age before you can use lopinavir. All right. Bacavir is not registered under 3 months of age. We do now have some data on using it from birth, not in prem babies, but from term babies. So if we get stuck, we can use a Bacavir in that situation. There's a lot more data on AZT. We don't have a therapeutic dose of nevirapine in neonates. We've got a prophylactic dose, but not therapeutic dose. There's a mathematical model dose, which people are using. Okay, and we know nevirapine is less effective under 3 years of age, and most of these kids have been on nevirapine for PMTCT, so they probably will have resistance as well. So we don't have much choices. We're giving them AZT3C and nevirapine. It's not a great regimen, but it tides them over until they get to a month of age when they can go on to, in the future, the dolutegravir regimen. So it's not long before. There is a raltegravir that you could use, not available in South Africa. It's problematic. It's difficult to do. You've got to increase dose in the middle. Difficult to formulate. And also we worry that people are going to keep using it and get resistance to dolutegravir, because raltegravir is similar to dolutegravir, but it becomes resistant much more quicker. So we'd rather just for 1 month, let them be on this regimen. The doses are not, for prem babies, are not on the dosage chart. You need to discuss with an expert, but from 2.5 kilos, it is on the dosage chart on the back if you turn over the dosage chart. Okay, and that's the algorithm. I'm not going to go through in detail. They are complicated. You got to keep on adjusting dosages depending on the gestational age, either 2 weeks or 3 weeks. 3TC dose changes at a month of age. So if you want to do it by yourself, fine. Otherwise, phone one of the helplines and we'll help you, tell you when to phone back, when to increase dosages, makes it much easier. And just to finish off on my favorite patients, the teenagers. Most of my patients have grown up and are now teenagers or young adults, and believe me, they remain teenagers at least 25 years of age. They all struggle with adherence. How do you get a teenager to swallow the tablets? And in my experience, there's only one way. You have to watch them swallow, because teenagers are the world champions at finding places to put their medication other than their mouth. They'll put it in their mouth, and as soon as the mom looks away, they'll come out and they'll find places, cracks in the wall, the toilet, under the beds. They'll find places to put it. So what you've got to do is get the parents to watch them swallow the treatment. Don't start when they're 14, when it's too late. Start when the brains are still reasonable, 9 or 10. Get them into the habit of, they can do everything else. They can remember, they can take it on their own, just swallow it in front of the responsible adult. Make sure that the treatment is given. That's the only thing that works in my experience. Disclosure goes a long way. If the patient knows what's wrong with them, they are more likely to take the treatment. But the problem with disclosure is we are scared to do it. The parents are even more scared to do it. They know nothing about HIV. They are feeling guilty. They're scared the child's going to tell everybody. So it's really our job to do, but we're scared to do it. Okay, we at Paediatrics are very much involved in training people on disclosure. We've developed a method. We developed flip charts that people can use to make life easier, to help them to do this. It's something that you need to do. It's very important. To help his parents to disclose. Yes, I've got the odd patient who's not taking treatment when they know what's wrong, but far more bigger problem when they don't know what's wrong while they're taking treatment. And last thing is teenagers will only talk to other teenagers, so get them together in a group. There's a whole set of topics that you can discuss. We've also got right here a nice flip chart which people use. It tells you what to say, and the other side's got nice pictures of teenagers to run a group, and every week's a different topic. Fantastic thing to do. And really, these are important principles to use in managing a teenager. I could talk, and I have spoken, I think, a few weeks ago on adolescence in HIV, so I'm not going to go into too much detail because we've done it all before. Okay, so in summary, children are different yet the same. They respond very well to ARVs. We just need to get them to take it. These new formulations are going to make a major difference, but please upgrade your patient's regimen. Don't leave them on the old, cell phone regimens from 2003. And with pleasure, make use of our helplines. We don't always have the answers, but we often know who does have the answers, and we can connect with those people. The adult and pediatric and adolescent is the 082-352-6642, and the TB helpline 063-698-6543. Okay, thank you so much, Lesego. I think I'm going to end it there. I see there are lots of questions. I've tried to answer some of them on the way, but we still got a few that need answering. Good. I don't know if you want to say anything before we get to the questions. Maybe I'll try and...
Yes, just to
paste.
Yes. No. As you sip a glass of water, just to appreciate the talk, I think you have covered things that I felt were very, very crucial and important around the differences between adults and children, and then coming to the regimens, and also the kind of support and some of the things that we sort of translate from the adult program to the pediatric program, but you find that they are not necessarily very effective for children, like same day initiation and stuff. So I think that was quite empowering. Maybe we can take, you can go through the Q&A, and then I'm gonna see as well if there's people who want to say something live, and then we can mix in between. Thanks,
Sure. Before we do it, Lesego, just an apology that I used the wrong slides. You didn't miss out too much. I did add in the bits that were missing, and also to apologize for the video. I'm not sure why it didn't work, but I will, as I say, I will send you the link to the video. I'm going to paste in the chat now before we start. We'll start off with just the dosage chart, the new dosage chart, so people can access that. And let's start with those questions. Okay. Should go back to the beginning. Okay, talking about neonatal dosages. All right, so yeah, I think I went through that. What factors to consider? The most important factor in treating a neonate is, can they swallow, can they drink, are they on feeds? Especially with the prem babies. They're not on feeds, you unfortunately have to delay it. They will only have one injectable antiretroviral in South Africa at the moment, and that's AZT. So you could give them that if you're stuck, but that's the most important clinical factor. Also, because we're using AZT, are they anemic? We used to use D4T as a replacement, but you can't get hold of D4T now. So now we do have this back of a dosage, which is, it's not the best data that I've seen, but when it's a pinch, we certainly can use a backup in that situation. So it's a good question. Okay. Why are we not looking at eradicating the virus? Yeah, sure. So yeah, we are looking at eradicating the virus. I'm sure people are working on it. There's a lot of research being done. I don't know if you remember the Mississippi baby, the baby that looked like she'd had a functional cure, but then turned out she didn't have. But there is a lot of research being done in children as well. I did answer about the decrease in bone density, so we can just say we've answered that. What you should say when the caregiver reports vomiting after giving ARVs. So you want to find out what is causing it. Most likely it's lopinavir. What I'm doing these days, I'm changing them to dolutegravir. There are dosages we can do at a push of the present formulations, but that's why phone the helpline will help you with that. But in hopefully a few months' time, you won't even have that issue. You'll just have the dolutegravir formulation available. In the old days, we used to try things like teaching them to swallow tablets, which you could do from 3 years of age and use the tablets. That's, I think you can do, but believe you me, the dolutegravir works much better. Yeah, I don't know the reference names for the back of a 3TC dolutegravir FTC. It's not even, it's still sitting at well, the pediatric one is still at SAPRA. The adult one is there are many different ones available. I don't want to bias people by giving trade names, but they are available. I'm not sure which ones are on tender.
Maybe Leon, on the question of vomiting, I wanted to check, are there salient things which people can sort of use to differentiate between vomiting as a side effect versus vomiting where something is really going wrong in children?
Yeah, that's a very good point. I mean, obviously you need to look at the clinical picture. Is it just the vomiting? Is it just related to the medication? You know, if they're vomiting at different times of the day, it's more likely that that's going to be something else. Whereas if it's literally, they say it's only when it's this medication, and they're not stupid, the parents, they'll stop the one and they'll give the other one and see which one does it. You know, so they'll come and say, this is the one that makes them vomit. Although I had an interesting call yesterday where they said, patient is, I want to take this patient off a Bacover. I said, why are patients vomiting a Bacover? What are they on? On a Bacover 3-TC favorance. I said, well, it's most likely the, sorry, not vomiting. This patient had a rash, So I said, the red of Bacover gives a rash. But a Bacover gives a rash as part of a multi-system disorder. Patient was otherwise well. It's just that otherwise well, that is not going to be a Bacover, that's efavirenz. So let's take them off efavirenz, put them on dolutegravir. They said, no, the mom said she tried the efavirenz on its own, it didn't cause a rash, and she tried the Bacover and it caused the rash. So I still don't think it's the Bacover. I still think it's efavirenz. But I said on balance, it's most likely to still be the efavirenz. But they try out. Okay, so yeah, so you look at the whole clinical picture and then see, you know, make up your mind which one it is. Okay, very good question. Someone says, do you put a 12-year-old female contraceptive and provide TLD for them? So maybe 4 years ago, yes, but not anymore, because now there's no problem using dolutegravir in people who are about to fall pregnant. Okay, we haven't got time to discuss that, but there's been they've looked at the research and that's changed now and it's no longer a problem. But thank you for asking. It's very important. Okay, thank you for asking. It's not a problem. Even adult patients, you don't have to give them the whole spiel about not falling pregnant. They can and they should fall pregnant on dolutegravir because it's going to suppress their viral load, prevent them transmitting to the baby. So there's no problem. You can use dolutegravir in pregnancy, and so we don't have to put them onto contraceptives. So but thanks for your question. Okay, our third-line patients kept in a database. If they're unfortunately demised, we need to notify the third-line committee. Please, not just if they pass away. We want to know about how are they doing. Remember, we are doing things which is right at the limits of our knowledge. Are we doing well? Are recommendations good? Are they suppressing? I want to know if they're suppressing, not if they're dying, God forbid, but certainly if they're dying. Please, if you could, it'd be wonderful if you could say the viral is suppressed. And if it's not suppressed, let us know and we'll see what we can do to try and help them. That's how we all grow. So very good question. Please, if you could let us know. Literally, we have got a database and we are interested in knowing what's going on and learning what's going on from these patients. We want to be part of the team, not just someone who gives a once-off decision and that's it. So thank you for it. It's a great question, but please involve us at every stage of the patient's journey. That would be lovely if you could. Thank you. Right, thank you. Opinion on CCNDDD for adolescent children with not optimal adherence levels. Okay, so look, it depends on the patient, depends on the regimen. There is no reason why you can't do CCNDD. I must tell you now, my private patients, I see them every 6 months and they do fine. They do fine. Okay, it's obviously you want to look at the patient, you want to look at, make sure they are suppressed. But there is and in adolescence, you need to watch more carefully, possibly. But if you've got a good system where you've got somebody watching them swallow, and there's no reason why you can't do CCNDD. But it's a great question, and I think we want to make our lives as simple as possible for all our patients, including the adolescents, because they don't want to come to the clinic because they've got other things to do. They want to get on with their lives. As I say to my patients, my aim with treating you is that you can live a normal life like everybody else, which means you just be able to go to school, just be able to do everything else everybody else does, get married, have children, have a job, okay, but not sit for at least 1 day a month in the clinic to get medications. You know what I'm saying? We must try and improve our patients' lives, but it's a two-way street. And if the patients can't do it, then they will not go to CCNDD. Okay, and they show us that they can't do it, then they won't be able to. So it's a question. Especially with the dolutegravir, it's very resilient. Okay, it's not like the old regimen which failed very quickly, had resistance very quickly. I must tell you now that some of my teenagers, God bless them, you know, they'll come to me and they say, "How am I doing, doc?" And I say, "Actually, you're doing well. Your viral load is suppressed. They're fantastic. It's doing well." And they say, "Oh, really? Eh?" Like they're surprised. I say, "Why? Because you're not taking it as well." They say, "Yeah, I'm not taking it as well." So I say, "Look, obviously this is much better than we had before. It does last longer, but it doesn't mean it's going to stay like this. You need to work on taking your treatment. So I think we must make our patients' lives as simple as possible. Fit the patients, fit the medicine into their lifestyle, not the other way around. It goes to the question of people saying, why we have to give GTG in the morning. If morning doesn't suit them, we give it at night time. Obviously, if they get insomnia, they move to the morning, but try and make it as easy as possible for the patients. I had one teenager who said to me, she takes the medicine at night time, but she always forgets. I said, well, why can't your mom help you take the treatment? She says, no, I go to parties, I come back late. So I said, so tell me something. Who lets you in the house when you come back late? Have you got your own key? No, my mom lets me in. I said, fine. When your mom lets you in, as soon as she opens the door, she gives you your medication. You know what I'm saying? Find out what their lifestyle is and fit the medicine into their lifestyle. Okay. And it means adapting. It means talking to your patients, finding out what works for them. Good. Are there any other questions? We've gone through.
Yeah, just maybe, I think Mervin, is also asking on the chat the issue of doing hepatitis B screening in children.
Yes. Okay.
Yeah, I thought maybe because of a high vaccination rate, maybe that's not as important. I don't know if there's any other.
No, it's a brilliant question. It's a brilliant question. We don't do it. And the reason is because we've been doing vaccinations since when? 1988 or something like that. But it's not that we don't see hepatitis B. It still is there. It's probably just not cost effective to do it on every single patient. And also remember, we don't have tenofovir for young children. So we give them 3TC, which works for about a year and then it stops working. So it's a really good question. And it's a question of, it's not common. And so we don't test for it, but it's not to say it's not there. As I say, I've had one patient, a 3-year-old who ALT went up. I did hepatitis B. It was positive. She was on 3TC. We discussed with the world experts who said because she was already on 3TC, she most likely had 3TC resistance. And so they suggested to put her onto tenofovir. We calculated the dosage. Luckily for her, it worked out as it is a pediatric dosage, but it worked out it was a half a tablet. Put her on that, and I don't want to lie to you, but what period of time? But she's seroconverted, and she's now free of hepatitis B. And,
all right, cool.
So
Arman,
it is there. It's a good question, but we're not doing it at this point in time.
Yeah, Arman in the discussion was asking about your pediatric discussion group. I know how I benefited from that in the early days, and she says, how does she join?
Okay, so it is a very good question, and it's a mea culpa. Okay, when it's not entirely my fault, and I don't know if she's still on, but
yeah, she's still on.
Juliet is still on, I think. So I've been discussing with Juliet. Okay, so what happened was during COVID, it was just crazy. I couldn't do it, and then we were using a very nice platform to do the discussion group. It literally took me 5 minutes to do. 2 seconds, and then they changed the platform, and now it takes me at least a half an hour. And I just don't have that kind of time. So I've approached Juliet, and we are going to resuscitate it. And with help, and I'm very grateful for the help from the Clinician Society, it's going to be resuscitated. I've already got a case, and we're going to put it on, and it's a lovely case for discussion. I'm sure you'd enjoy it. I'm going to hope to do it before our anniversary. We started it in December 2000. So we will be 22 years old in December. I'm hoping to get out the case now before the anniversary, so that you can all mull over it during the holiday period. Thank you for that. I think if you are interested in joining, you can drop Lesejo an email, and he can forward it to me, or you can, if you've got my email address, you're welcome to send me an email address. I'll put people on as soon as we start again. But thank you. It's something that I feel very bad about, but as I say, I have approached Juliet, and thanks to help, we are going to resuscitate it. For those of you who don't know what it is, it's an email-based learning program where we send out cases, people discuss, at the end we get experts to discuss, and we get really interesting cases. And we have 2,000 people on the mailing list at the moment, and we'll hope to get more. So I don't mind putting my email address there, and people can just email me if they're interested, and I'll add you to the mailing list.